Next presenter is Dr. Jason Dominitz. He is the professor of gastroenterology and medicine at the University of Washington. He is the National Program Director for Gastroenterology in the Veterans Health Administration. And he is going to talk about organized colorectal cancer screening outreach efforts in various countries and health systems. Please, Dr. Jason.
Thank you, Adriana. I really appreciate the invitation to speak this morning about organized screening, and this talk, I think, follows nicely upon the work that Linda Rabinek has just talked about. So Schroeders et al. Had a very nice paper in 2015 outlining colon cancer screening around the globe. And as you can see in gray, these are areas where we don't know what kind of screening is going on at that time. In the shades of orange is opportunistic screening, and in green is population-based organized screening. Linda Rabinek wrote a nice paper in Gastro last year with Graham Young and Sid Winnower, showing the significant uptake and adoption of colon cancer screening around the globe. As you can see in green, these are the population-based organized programs. In yellow are pilot programs, and in red are structured opportunistic programs like what we have in the United States and in some areas in the US, for example. I don't have time to go through the details of this slide, but I call your attention to this paper in the World Journal of Gastro a few years ago. Now, these data date from programs sometimes back into the early 2000s. So the numbers that you're seeing in terms of participation rates, et cetera, may not be reflective of the current participation in these countries. But I think it's interesting to note the differences around the globe in terms of the type of test used, and of course the age ranges at which screening is undertaken, but the use of FIT versus guaiac FOBT, participation rates, which I'll touch on more in a moment, differences in positivity rates, and follow-up colonoscopy. Here we see data from Asia and the Americas with similar types of variation to what I showed in the European data on the prior slide. So lots of variation, and I think we can learn a lot by looking at the variation and the details of how these programs are designed, as Linda Rabinek just touched on. So here we see the reported variation in participation. You see Canada is at 16%. Now this is in the first year of that program, and as Dr. Rabinek just detailed, their participation rates have increased over time. So what can we learn from looking at the variation in participation? Well, I think if we look at different aspects of the program, it can give us some insights into what is contributing to these differences in participation. For example, use of guaiac FOBT tends to be at programs at the lower end of the spectrum in terms of participation rates. Also, as Linda Rabinek was just talking about, the way the invitation is done is very important. So in I, these are places where patients get, or individuals get, an invitation to be screened, and then they often have to go to their general practitioner to get the screening test. In G are programs where they say it's general practitioner based. In Italy, there's pharmacy distribution of FIT kits. So the patients don't have to go in to see a doctor and potentially have expense of that. They can just pick it up at their local pharmacy. And M are mailed FIT programs. And you see that in general, the mailed FIT programs are at the higher end of the spectrum of participation. There's a wonderful paper in the Journal of Medical Screening earlier this year detailing 4 European programs in France, Flanders, Netherlands, and Basque Country. And here you see the cutoff level for a positive FIT test varies from country to country. The use of pre-invitation letters varies. Whether or not the FIT is mailed varies. The use of reminder letters, both the timing and frequency of reminder letters is different. Then there's different exclusion criteria for people to be screened. And you see in the last column that some countries have no exclusions mentioned in the invitation letter, while others exclude people with colon cancer, occult blood, change in bowel habits, colonoscopy in the last 10 years, et cetera. So we can learn a lot by looking at these comparisons of these countries and then comparing it to the participation rates and the diagnostic yield. And so you see that the Netherlands and the Basque Country have the highest participation rates and the highest diagnostic yield, and those various factors in the design of the study, as Linda Rabinek just talked about, contribute to the outcomes that they see. Now in the US, we don't have organized screening programs in general. I'll touch on one that we have in Kaiser, for example, in just a few minutes. But we do have high rates of overall screening. There's a lot of use of colonoscopy. So overall, about 2/3 of the US population is up to date with screening, which is not bad. It certainly could be better, and we want it to be much better. In the VA where I work, the Department of Veterans Affairs, we've been seeing about 80% uptake with colon cancer screening. Most of this is through colonoscopy. We do have a policy for screening. We do have clinical reminders that are in use, and we are exploring a mailed fit program modeled after what Kaiser Permanente has done. But we do have problems. For example, diagnostic colonoscopy after a positive FOBT. I envy the rates that Linda was talking about, where she, I think, said 62% diagnostic colonoscopy rates. In the VA, it's a little lower than that overall. But here you see results from about 140 medical centers in the VA, and you see that there's tremendous variation, with some sites being close to 100% diagnostic colonoscopy after a positive FOBT. And so we're trying to learn what are the factors that contribute to these higher participation rates, and how can we get these lower performing sites to get those better results. And if you look around the globe, again, we see the significant variation in diagnostic colonoscopy after a positive FOBT. There's a nice paper from Taiwan that comments on the fact that FIT and diagnostic colonoscopy are covered by the health insurance, but the cost of moderate sedation is not covered, and they feel that this may be contributing to lower adherence with diagnostic colonoscopy, which was also brought up in the paper comparing the 4 countries in Europe. France, for example, has more costs with colonoscopy. Now, I want to finish up by talking about the Kaiser Permanente program in Northern California. There's a paper by Selby et al. That just came out in press in the past week. It's available at the link shown below. They describe the details of their program, where they start with a pre-invitation letter mailed to individuals who appear to be due for colon cancer screening. And then they follow that up with a FIT kit that's mailed to the individuals. And if they don't return the kit, then a robocall, a telephone call, is made to the individual, reminding them to send in the FIT kit. And if that doesn't work, a postcard is mailed. And after that, the local clinics take over and secure message the patients, make individualized phone calls to the patients. And they also have what they call InReach, where patients are encouraged to get screened when they're in the doctor's office. They have clinical reminders, their prompt system to remind them. They also administer FIT kits during flu vaccines. So they do a lot of InReach to increase their screening. And as you can see on this slide, they start with 40% of individuals being up to date due to prior colonoscopy or sigmoidoscopy. And through mailing the FIT kit, robocalls, reminders, they're increasing their overall coverage up to the point that they get to 81% coverage. If you factor in other colonoscopies, sigmoidoscopies, and guaiac FOBT, they get to 82% coverage, and their diagnostic colonoscopy rates 81%. So I think this is a model for an excellent organized screening program. And you can see that their use of FlexSig over time has decreased here in the open circles. Their use of colonoscopy has been increasing over time. But when they instituted this FIT program in 2006, 2007, you see that their overall screening rates met the 80% benchmark that we aim for in the United States. They also saw a spike in cancer incidence. Here you see around 2008, cancer incidence went up as they increased their screening outreach efforts. And they saw a decline in overall colon cancer mortality. Now, I do want to call your attention to a recent CDC-sponsored summit on mailing fecal immunochemical tests that was led by Samir Gupta and Michael Pignoni and others. I don't have time to talk about this document, but I encourage you to read it. It came out earlier this year talking about some of the evidence we have around various aspects of organized screening programs. So with that, I'll close with just stating that organized screening is increasingly being adopted worldwide. There's clearly a lot of variation in the organized screening methods, around age, exclusions, type of FOBT, et cetera. And as Linda said, every program is perfectly designed to get the outcomes that they see. I think we know that improved participation results come from mailing the FIT test. And that I think one of the biggest challenges we have is to make sure that participants who do get screened with FIT and other 2-stage screening tests, go on to that diagnostic colonoscopy. I think we can learn best practices from these highly successful programs. So again, thank you for this opportunity to talk about organized screening programs. I'm happy to take any questions.
Thank you very much for your presentation. Very nice. What's the cutoff that you are using in the United States, Dr. Jason? The cutoff for FOBT?
We use 20 as our cutoff in the US, yes. That's the FDA clear level for the polymedco test. That's the ICON OC sensor test. Yeah.
Mm-hmm. Another question, somebody? What do you suggest for implementing this worldwide colorectal cancer screening? It's a challenge for us in Latin America. It's even more difficult. Should you start with age of 50, or do you think that we should move to 45, or keep it to 75, or go older to 80? What's your opinion?
Those are great questions. You know, in the US, the current guidance is to screen from ages 50 to 75. I think, you know, a lot would depend on what resources you have. As you saw in the earlier slides, some countries have focused on older or narrower ages like 60 to 69, for example. And I think if you're starting a new program and resources are limited as they are in most parts of the world, it may make sense to focus your efforts on the highest yield population and then expand as resources allowed. You know, one of the reasons for the variation in the cutoffs, for example, the Netherlands had higher hemoglobin threshold was due to limited colonoscopy resources. In the VA, we, because of COVID especially, we're trying to institute a mailed FIT program, but there are significant costs and challenges to doing that. So, you know, I think that every program, every country should look at what resources they have, and I would encourage using, starting with pilot programs. But there's a lot to be learned from our experience around the globe, like the Netherlands, for example, is a great model, and programs like Kaiser.
And just one question about Dr. O'Moran. Do all the participants have insurance in the United States?
So as many of you may know, the United States does not have a universal healthcare system. In the VA where I work, you know, the veterans all have health insurance, but there's some variation in copays that they may have based on something called service connection status. But across the US, we have millions of Americans who have no insurance whatsoever. And, you know, and when they do have insurance, it's not through a unified system. There's a patchwork of different private insurance companies, government insurance for people over age 65, Medicaid for the poor. The 67% or so overall screening adherence that I showed you earlier varies by insurance status, for example, varies by poverty status. So there definitely are challenges in the US in that regard.
Thank you very much.